Welcome. If you're a coding student trying to get a handle on one of the more complex areas of cardiovascular procedures, you have come to the right place. Today, we're going to decode the CPT guidelines for ventricular assist devices. We'll turn these complex rules into a clear, logical path that you can actually use. Okay, so let's dive right in by meeting our main character, the ventricular assist device, or VAD for short. You can think of it as a mechanical pump that it gives a helping hand to a weakened heart. For us as coders, knowing what it is helps you make sense of what the physician is doing in their report. So here is the most important thing you need to grasp right from the very beginning. Every coding story for a VAD starts at a major fork in the road, and that's the approach. Was the device placed percutaneously? Through the skin, or was it a transthoracic, which is a full-on surgical approach? Trust me, this single detail changes absolutely everything. So here's our game plan for this explainer. We're going to follow the entire life of a VAD from a coder's point of view. We'll start with the basics, then move to insertion, what to do with adjustments, and finally removal and replacement. And then we'll wrap it all up with a super handy checklist.
All right, let's start with those foundational principles. These are the things that will guide every single decision you make when you're staring at a VAD operative report. If you can get these right, everything else just kind of falls into place.
It really just boils down to answering two simple questions about what the doctor did. First, what was the approach? We just talked about it. Was it percutaneous or transthoracic? And second, what was the procedure? Are we looking at an initial insertion, a little repositioning, a removal, or a total replacement? Your answers here will point you to the right family of codes every single time. Okay, let's move into our first chapter, when the device is actually put in. This is usually the most straightforward part of the whole journey, but it really does set the stage for everything that might open later. So this is the first big event in the patient's timeline. And remember that very first question we asked, the approach? Well, for insertion, that is all that matters. The CPT codebook literally splits the insertion codes into two totally separate groups based on whether it was percutaneous or transthoracic. Now check this out. This slide shows you just how clear that separation is. Over on the left, you've got the codes for percutaneous placement, like 33990. And on the right, you've got the codes for the surgical transthoracic approach, like 33975. As a student, this is one of those things you just gotta lock in. These two code families do not mix and match when you're coding the initial insertion. But, what happens if the device needs a little tweak after it's been placed? The initial placement might not be 100% perfect, and the physician might need to go back in. So let's dig into the very specific rules for how you code that situation. And this shows you the really strict conditions you need to hunt for in the documentation. So if the doctor repositions the device during the same exact surgery as the insertion, you can't code for it separately. It's just considered part of the main job. For repositioning to be a billable service, it has to happen in a separate session. And, this is crucial, the physician has to use imaging guidance to do it. Only when you see both of those things in the notes can you report code 33993. And now we get to the end of the device's journey, which, not gonna lie, brings some of the trickiest coding rules. This is where your attention to detail in the doctor's notes becomes absolutely critical. Okay, here's a classic scenario that trips up so many new coders. Let's tackle it. Imagine a patient gets a temporary device put in the morning, but their condition changes, and it has to come out that same afternoon. How in the world do you code that? The key phrase to burn into your brain here is distinct service. Your job as a coder is to be a detective. You have to find proof in the documentation that the removal was a separate, totally necessary event, not just the doctor changing their mind mid-procedure. If you can prove it's distinct, you report the removal code and slap on a modifier 59 to tell the story. This is another huge question, because VADs aren't just one single thing, right? They're systems. And the answer here completely changes how you're going to code it. You've got to read that op report so carefully to figure out exactly what was taken out and what was put back in. This table right here is your ultimate cheat sheet for replacements. Look closely. If only the pump gets swapped out, you're going to use those specific replacement codes you see in that top row. But, and this is the part that gets people, if the entire system is replaced, you basically hit the reset button. You code it as a brand new insertion, and you do not report a separate code for the removal. It's just considered part of the whole replacement job. Okay, we have covered a lot of ground, so let's pull all of this together into a simple but really powerful checklist that'll guide your thinking every time you come across a VAD case. So the key is to just mentally walk through these questions, right? In order. Think of it like a decision tree. You start with the approach, Then you identify the procedure, and from there you ask those very specific follow-up questions about timing or imaging or what parts were involved. If you follow this logic, it will lead you to the right codes and help you avoid so many of the common mistakes. So to wrap this up, just think about everything we've covered. Was it that distinct service rule for a same-day removal? Or maybe the difference between replacing just the pump versus the entire system? Go back and take another look at that one area that felt the most confusing. I promise, that's how you turn these complicated guidelines into real coding confidence.